In this video, we will be discussing oral pathology doubts from the chapters Lesions of Skin and Bone Diseases. So the first doubt is difference between Erythema Multiforme and Stevens-Johnson syndrome. Erythema multiforme is an acute self-limiting dermatitis characterized by distinct clinical eruptions which manifest as raised atypical target lesions. Now it is a spectrum of disorder, with erythema multiforme minor being extremely mild, and then we have erythema multiforme major, Stevens-Johnson syndrome, and lastly the most severe form is toxic epidermal necrolysis. Erythema multiforme is characterized by asymptomatic lesions which are present as discrete macules or papules with a symmetrical distribution, usually present on the trunk, face and extremities. And as you can see in this picture, you have a concentric ring-like appearance due to varying shades of erythema, lending the term target iris or bullseye. The lesions usually appear in 1-2 days, persist for several days to weeks, and then they gradually fade away. Now, let's move on to the extreme end of the spectrum, that is your Stevens-Johnson syndrome is the most severe form, and it is a type of delayed hypersensitivity reaction which begins with fever, malaise, photophobia, eruption of oral mucosa, genital mucosa and skin. So there is a more widespread involvement. So within the oral mucosa, the lesions, these macules, papules and vesicles will rupture and ulcerate, and mastication will become extremely painful. The lips will also ulcerate with blood crusting. The eye lesions will cause photophobia manifesting as conjunctivitis, corneal ulceration and panophthalmitis. This can even lead to blindness. We see genital lesions like urethritis, balanitis and vaginal ulcer. Now, toxic epidermal necrolysis is very serious, fatal bullous drug eruption with large sheets of skin peeling off, giving appearance of scalded burns. Now, the etiology for erythema multiforme is unknown. However, it is the minor forms have been linked to certain drugs like sulfa drugs. Certain infections like herpes simplex virus infection is known to trigger erythema multiforme minor. Mycoplasma has also been associated with it. Now, the other two doubts associated with it, with erythema multiforme were which type of hypersensitivity reaction is it? It is type 4, as I already mentioned. And lastly, one of you had asked, there was a question, erythema multiforme is an acute self-limiting disease of skin and mucous membrane. B, painless vesicular self-limiting disease. C, a viral disease. D, a bacterial infection. So out here, given options, we will go with option A. It is an acute self-limiting disease of the skin and mucous membrane. We do not go with the option of a viral disease because it is not caused by a virus. A viral infection can trigger this reaction. Now moving on to our fourth doubt, which says generalized thickening of cortical and cancellous bones is seen in. And your options are option A, osteopetrosis, option B, Paget's disease, option C, osteogenesis imperfecta, and option D, infantile hyperostosis. Correct answer here is osteopetrosis. Now, pay attention to the wordings of the question, generalized thickening of both cortical and cancellous bones. So osteopetrosis, as we know, is failure of osteoclast to resorb the bone. So this will result in thickened sclerotic bones with poor mechanical properties. Now, the mechanical properties are poor because of failure of collagen to augment the bone matrix from defective remodeling of woven bone to compact bone. Now, why we will not go for infantile hyperostosis is that usually in infantile hyperostosis, it's only the cortical thickness, unusual cortical thickness of bone. What happens here is there's inflammation of the periosteum. So the periosteum will become thickened. And as the lesion progresses, now infantile hyperostosis is also a self-limiting disorder. Mature lesions will show hyperplasia of lamellar cortical bone. Now note that out here, this periosteal cloaking is confined only to diaphysis of long bones, sparing your metaphysis. Now moving on to the fifth question, a patient complains of loss of visual acuity, deafness and enlargement of maxilla. Well, your options are option A, Paget's disease, option B, osteomalacia, option C, fibrous dysplasia, and option D, osteogenesis imperfecta. So the options are pretty straightforward. We'll immediately go for Paget's disease. Paget's disease involves abnormal remodeling of bone and loss of visual acuity because of compression of optic nerve, deafness due to compression of cochlear nerve, facial palsy due to compression of facial nerve, and enlargement of maxilla, which is the most commonly involved bone in the facial skeleton in Paget's disease, and platybasia, that is descent of the base of brain into the cervical spine, are the most common features of Paget's disease. Our next doubt is about the splits in all forms of epidermolysis bullosa. Epidermolysis bullosa are a group of inherited bullous disorders characterized by blister formation in response to mechanical trauma. Now, the various types are epidermolysis bullosa simplex, junctional epidermolysis bullosa, dystrophic epidermolysis bullosa, which has a dominant and a recessive form, and a new variant which is known as hemidesmosomal epidermolysis bullosa. So now the split is seen histologically. So we'll just understand this with the help of a diagram. In your simplex version, it is an intraepidermal skin separation. As you can see, there is destruction of basal and suprabasal cells, and the basement membrane, which is marked in bright pink because it's PAS positive, is on the dermal side of the separation. Now let's look at your junctional. Now, junctional, as the name is suggesting, the skin separation is in the lamina lucida of the basement membrane. Now, this is seen via electron microscope. Basal lamina has 3 zones. Here is your epithelial cell, the basal cell. Then we have lamina lucida, lamina densa, and sublamina densa. The split is here, as shown in the diagram. Then we have dystrophic epidermolysis bullosa, where again the basement membrane is divided and the basal cell layer of cells is flattened and will appear on the roof of the blister, as you can see. The last one, which is a relatively newer discovery, the hemidesmosomal epidermolysis bullosa, where blistering is at the hemidesmosomal level. That is in the most superior aspect of your basal lamina. Our next doubt is why are levels of alkaline phosphatase normal in cherubism but elevated in polyostotic fibrous dysplasia? So alkaline phosphatase is an enzyme that is present in various tissues of the body, particularly in bones, liver and kidney. And elevated ALP levels are a sign of certain medical disorder. So, in fibrous dysplasia, as the name is suggesting, the fibrous tissue will replace the normal bone. That's why the term fibrous dysplasia. The ALP levels are elevated because of increased bone turnover and bone remodeling. The defect lies in the osteoblast maturation and differentiation, resulting in high levels of ALP. Now, in cherubism, which is a rare genetic disorder characterized by benign tumors of the jaw, the bone levels of ALP are within normal because the tumors does not affect the bones in a way that will lead to altered ALP levels. Now, the third bone disease, that is your Paget's disease, also shows elevated ALP levels because bone is being broken down and repaired at an accelerated rate, leading to increased ALP levels. That being said, in Schaefer's, I'm enclosing the page and it is marked here, it is highlighted here. Sometimes in cherubism, ALP levels may be elevated. Moving on to next questions, anti-nuclear antibodies are seen in SLE, systemic sclerosis, morphoid, all of the above. The correct answer is all of the above. SLE has anti-nuclear antibodies. Systemic sclerosis shows presence of SSC, anti-SL70, which is anti-topoisomerase, and anti-centromere bodies. And morphia shows presence of anti-SSARO or anti-SSBLA antibodies. The explanation for this in detail is also given in one of the previous videos. So please have a look at that and correlate. Now moving on to the next question. A 40-year-old woman reports with a complaint of burning sensation in mouth. Clinical examination reveals lesions consisting of radiating white striations in a retiform arrangement affecting the buccal mucosa, tongue, lips and gingiva bilaterally. An incisional biopsy is suggestive of Lichen planus. The following are different clinical forms of Lichen planus, except your options are A. Atrophic Lichen planus, B. Hypertrophic Lichen planus, C. Bullous Lichen planus, and D. Verrucous Lichen planus. Correct answer is D. Verrucous Lichen planus. Lichen planus is a common mucocutaneous disorder, and clinically it is seen in your reticular form, which is the classic papules in linear, annular or retiform arrangement. They have a white lacy appearance, as you can see in the picture, and the tiny white dot at the intersection of these lines is known as striae of Wickham. Then we have an bullous form, which is extremely layered, which is characterized by vesicles and bullae. Then there is an erosive form where we have eroded and frankly ulcerated lesions which are irregular in size and shape and are extremely raw and painful. And on the periphery we can see the radiating white thread-like striations. Then there is an atrophic Lichen planus, which clinically will resemble the erosive Lichen planus. And we also have an hypertrophic Lichen planus, which resembles the leukoplakia. The next question is, hyperpigmentation is seen in all except Peutz-Jeghers syndrome, B. Addison's disease, C. Cushing syndrome, D. Albright's syndrome. The correct answer is Cushing's syndrome. Now let's look at all the options which have pigmentation. Peutz-Jeghers syndrome is an autosomal dominant syndrome characterized by multiple polyps in the intestinal tract and perioral pigmentation. The polyps are known to increase the risk of development of colorectal cancer. Then we have Addison's disease. Now Addison's disease is characterized by inadequate production of hormones by the adrenal glands. So this in turn will stimulate the pituitary to secrete more ACTH. Increased ACTH is known to stimulate production of increased production of melanin from the basal cells, resulting in pigmentation. Then we have Albright's syndrome, which is also a form of polyostotic fibrous dysplasia, along with cafe-au-lait spots and precocious puberty. Now, the characteristic feature of this pigmentation is that this is ipsilateral to the correct side of the bony lesion. Now, Cushing syndrome is a disorder of the adrenal glands characterized by excessive production of cortisol hormones. Our 11th question is the association between porokeratosis of Mibelli with cornoid lamella. Now, porokeratosis of Mibelli is a rare genetic keratosis known to have a dominant inheritance, and it is characterized by faulty keratinization of skin followed by atrophy. So the clinical features are it's more predominant in males, and initially the lesions will appear as a crateriform keratotic papule which will enlarge to form elevated plaques which will measure in length from several meters to few centimeters. The most commonly affected site are your extremities and nails. Later on, the central portion of the lesion will become atrophic, resulting in permanent scarring. Now, the histological feature is your cornoid lamella. What happens here is that there is hyperkeratosis and acanthosis with deep groove which is filled with parakeratin and characteristic absence of underlying granular layer. which you see in normal skin. And this structure is known as your cornoid lamellae. The central portion shows atrophy, and the underlying connective tissue will show lymphocytic infiltration. So, cornoid lamella is the histological feature of porokeratosis of Nibali. Our next doubt is comparison between Kafi-Silverman disease and cherubism. Now, Kafi-Silverman disease is your infantile cortical hyperostosis. Now, though both are childhood diseases of bone, and both have an autosomal dominant mode of inheritance, and both are self-limiting in nature, but the clinical features and histological features will differ. In infantile cortical hyperostosis, it's a triad of irritability, swelling, and inflammation of the bone. So, to be very specific, there is inflammation of the periosteum and the adjacent soft tissue. So, there are two forms. There's a familial form and there is a sporadic form. So, in the familial form, oral manifestations are less common. Tibia is the most frequently involved bone. Sporadic form shows involvement of your mandibular bone. And the classic feature is that there will be new periosteal bone formation, and beneath this new periosteal bone formation, we will have subperiosteal lamellar bone. Now, our cherubism will show, on the contrary, now this has an asymmetric enlargement. So, in cherubism, we will see symmetric maxillary and mandibular enlargement. So, particularly, we'll have florid maxillary involvement, cervical lymphoid hyperplasia, and because of this maxillary enlargement, the palate will become V-shaped. In fact, a classic feature is blue sclera and eye to heaven appearance, because the rim of sclera is visible beneath the iris. Now, histologically, this cherubism is very similar to giant cell lesions, because it will show presence of numerous giant cells and perivascular eosinophilic cuffing. The radiological features will include, it's a multilocular cystic lesion, and due to presence of numerous uninterrupted teeth and destruction of alveolar bone, it can displace the teeth, giving a floating teeth syndrome. Now, during adulthood, there will be reossification of these cystic spaces, giving rise to patchy sclerosis, and that's why the diagnosis comes under confusion with fibrous dysplasia. Moving on to our 13th question, in cicatricial pemphigoid, which antigen is bound to IgG on the epidermal side of the salt skin technique? And your options are option A, 17 collagen, option B, epiligrin, option C, laminin, and option D, BP antigen 1 and 2. The correct answer here is option A, 17 collagen. Now, as we know, cicatricial pemphigoid is a blistering disease which affects the mucous membrane of the oral cavity, conjunctivitis, and genitalia, and these lesions will heal by scarring. And histologically, the blisters are subepidermal in nature. So, when we do the split salt skin technique, the IgG antibodies will bind to BP180 antigen in the hemidesmosomes on the basement membrane of the skin lesion. Now, your other lesions, your pemphigoid, also the antibodies will bind to BP180 antigen. For pemphigus, the antibodies will bind to desmoglein 3 and desmoglein 1, which are desmosomal adherents present on the epithelial cells. Now, next question is alkaline phosphatase increases in, and your options are A, Paget's disease, B, osteopetrosis, C, cherubism, D, fibrous dysplasia. The correct answer here is going to be Paget's disease. Now, even though alkaline phosphatase levels are increased in both fibrous dysplasia and Paget's disease, the amount of increase, or you can say there's a marked increase in Paget's disease because of rapid turnover of bone, rapid remodeling of bone. Now, moving on to the next question. Most common site for Acanthosis nigricans is, your options are tongue, buccal mucosa, floor of the mouth, and D, vestibular mucosa. The correct answer here is tongue. Acanthosis nigricans is an uncommon dermatosis, predominantly seen as a benign and a malignant form. Malignant form is associated with lymphomas and carcinomas of intestines. Now, the clinical features will show that it has an equal prediction for males and females. The most common site in the oral cavity are tongue and lips, and the appearance will be, there will be hypertrophy of filiform papillae with shaggy papillomatous surface, and the lesion will have overall velvety appearance. Now let's discuss the next question. The most common cause of secondary hyperparathyroidism is, and your options are A, end-stage renal disease, B, hypovitaminosis D, C, decreased dietary intake of calcium, and D, tumor of parathyroid. The correct answer here is A, end-stage renal disease. Now, as we know, parathormone is produced by parathyroid glands. Now, hyperparathyroidism, that is excessive production of parathyroid hormone, can be of two types, primary and secondary. It's known as primary when the cause is within the thyroid gland, which is usually the most common cause for primary hyperthyroidism is your benign tumor. And this will result in excessive calcium, raised calcium levels in the blood. So there will be hypercalcemia. Now, secondary parathyroidism happens because of some other condition like an end-stage renal disease, a chronic kidney disease, which will result in decreased production of vitamin D. If you remember vitamin D metabolism, the last step happened in the kidney. So because of decreased vitamin D levels, the blood levels in the calcium will drop. So there will be hypocalcemia. And this hypocalcemia, in turn, goes back and signals the parathyroid glands to secrete more parathyroid